Okay. Okay, good. So we can start?
Yep.
Sure. Okay. So it is a real pleasure for me to introduce Dr. Yousef Tizabi, who is a researcher and a friend for us. And to tell you just a brief summary of his background, Dr. Tizabi received his BA in physics at the University of California at Berkeley in 1970 and his PhD in physiology at Georgetown University in 1974. And then he followed a postdoctoral fellowship in the Laboratory of Clinical Sciences, NIMH, and he joined the Howard University in 1976, where he's currently professor of pharmacology. He has participated in NIH Tutor Section and has been reviewer for several foundations and numerous scientific journals, and has served on the editorial boards of several journals and served as associate editor for neurotoxicity research. He has over 165 peer-reviewed publications, and some of his seminal articles have been cited more than 200 times each. Recently, he was invited to be a guest editor for a special issue in journal Receptors under the title Nicotinic Receptors from Molecules to Benchside. Dr. Tizabi's main areas of research involve elucidation of neurobiological substrates of mental and neurological disorders, including depression and Parkinson's disease, with the hope of providing more effective treatments. So, Yousef, it's a pleasure to have us among us in this virtual seminars, and the floor is yours.
Thank you so much, Marta, for that kind introduction. It is really a pleasure for me to share some of our work with you in Argentina. I was there, as we were talking before the start of this session, in Buenos Aires last month, and had the pleasure of visiting the University of Buenos Aires with Marta, with whom we have a collaboration going on, and hopefully this will add to our further collaboration between us and any university in Argentina. So before I talk about the topic, I want to tell you a little bit about Howard University, which was established in 1876. People sometimes think Howard is Harvard, but this is two very distinct universities. We have the same initials, HU. However, Howard has one other similarity with Harvard in that we are the first historically Black college or university versus Harvard being the first white university, if you wish. So in 1876, right after the Civil War, General Oliver Otis Howard, who was in Lincoln's cabinet, to give a tribute to the Black soldiers that had fought with the Union against the South, to give a center of higher education to Blacks, and he petitioned the Congress, and they agreed to establish basically a seminary school. And a year after, they established the College of Medicine. So we are over 155 years old, and the campus is, I can't advance. Let's see. Okay. The campus is now located in a very strategic position. This was the house of the General Howard, which still stands on the campus. And the university now is in a very nice area of Washington, Northwest. There's the reservoir, and it has now expanded to about 10,000 or so students, practically all disciplines. And the motto for the university was to provide education for those who could not otherwise find it other places. But in the 1960s, with the civil rights movement and advent of Black students to other universities, Howard still maintains that. And up to date, we are one of the biggest graduates of minority students, especially in College of Medicine, law school, and so on. And this is the College of Medicine. I'm on the third floor of this building, and if you visit me, this would be the view. This is a nice new library. So I hope to have you some day in this place. Now, two different things I'm going to be talking about, nicotine and alcohol. And basically, I'm going to be sharing 4 concepts in each. Why addiction in general, and to nicotine and alcohol in particular, the comorbidity with psychiatric disorders, specifically depression, but others as well. What are the neurochemical underpinnings of addiction? How does age and gender play a role in all this? So with nicotine, when we talk about nicotine, everybody thinks of smoking cigarette, and that's really the case because people smoke to get nicotine, and that's the highly addictive component, but it is one of the most hazardous practices. And as you see, there are quite a bit in the United States, almost 500,000 die a year because of this preventive. It seems like no matter what we do, it used to be that this incidence of smoking was really high, about 50%. Now it's about 20, 22%, and it seems like we cannot get it below that. And this is all because of this component, nicotine, which is so highly addictive. It comes from these beautiful flowers that eventually leads to tobacco. But nicotine itself is used because it's stimulant. It gives a little oomph. It's highly addictive, as I mentioned, but people might smoke because when they take a cigarette, they say, oh, it's calming me down, anxiolytic, versus anxiogenic, which means it would cause anxiety. So it calms down anxiety. It has antidepressant effect. And actually, the incidence of smoking in depressed population, like I said, in general population in United States is about 20, 22%. But if you look at a depressed population, you would see that the incidence of smoking is at least twice, if not more. So we are thinking that people with depression are kind of self-medicating themselves with nicotine through smoking. And this is even higher incident in psychiatric conditions, specifically schizophrenia, where the patients are practically chain smokers. And we still think that they are trying to derive some remedy or some self-medication with nicotine again. And in addition, it has cognitive enhancer, and I'll talk about this a little more later. It also has analgesic effect and neuroprotector, which I'll emphasize. An analgesic effect, nicotine, I must say there is a compound called epibadidine that is derived from the skin of the Ecuadorian frogs. It is 100 times more potent than morphine, but it has, of course, side effects. The fact that it acts on nicotinic receptors gives the idea of nicotine having analgesic effect. Then you also have other therapeutic potentials, ADHD, attention deficit hyperactivity disorder. Basically, mothers who smoke during pregnancy can have higher incidence of ADHD, but if you have someone diagnosed with ADHD, nicotine itself, being a stimulant, could be helpful. Same like what we use right now for ADHD, stimulant, amphetamine derivatives, etc. Same with Tourette syndrome, obsessive compulsive disorder, or some inflammatory conditions like ulcerative colitis because it has anti-inflammatory effect. So when smoking kills, nicotine itself might have tremendous therapeutic potential. Talk about this in a later. So nicotine has been considered a sacred chemical in many Native American ceremonies. Tobacco is used to unify the participants with their spirit powers. It is used to honor the earth and the creator. It is offered as a gift to show respect, smoked to signify peace, and burnt to purify and protect. So this I saw in Botanical Garden in Washington, D.C. I thought it's very appropriate for when we talk about nicotine, not tobacco necessarily. So how does all this effect come about? It's because of the action of nicotine on nicotinic receptor, which is a ligand-gated ion channel receptor, and it is a fast-acting, of course, compared to the G receptor-coupled GPCR receptors. And basically, you have 5 subunits that combine to make this pore. The subunit compositions, alpha, beta, delta, gamma, can combine in many different ways. And you have these receptors in neuromuscular junction, without which we would not have any muscle contraction. You have them in autonomic ganglia, which control all the autonomic function, and you have them in the central nervous system. However, the composition of these subunits in each area is different. Like, for example, in skeletal muscle, you have delta and gamma, whereas in ganglia and CNS, you have alpha 4 beta 2 or alpha 7. So they are up to date now. You have 16 different subcombination, and we know a lot about this receptor because they were the first to be isolated from the abundance of them in a string array. And we now know, of course, we don't have nicotine in the body to have these nicotinic receptors. Of course, this respond to acetylcholine. That's why we call them nicotinic cholinergic receptors. And the cholinergic pathway in the brain, you have few of them that are critical in practically many aspects, but specifically cognitive function. So you have the septohippocampal, you have the pontin to the lateral dorsal, etc., and the nucleus, basal nucleus of minor. So the involvement of cholinergic in cognitive function, specifically dementia and Alzheimer's disease, is the fact that it is the first neurotransmitter to be affected. I'll contrast this later with dopamine that gets basically diminished in Parkinson. In Alzheimer's, it's the cholinergic system. And to remedy this deficiency, what we have, unfortunately, is very limited efficacy. The problem is that acetylcholine, it gets breakdown very quickly in the synapse. As you know, it has both nicotinic and muscarinic receptor, but our concern is more nicotinic receptors. And to increase the function or duration of acetylcholine, the remedy in Alzheimer's used to be tacrine. Now you have donepezil, that basically they inhibit acetylcholinesterase to increase the level of acetylcholine, not to have it broken down. So, but still, donepezil in combination with mantin now, that is a mild glutamatergic agonist, have very mild efficacy. So we really need some more specific and more effective compounds. And I believe that nicotinic agonists themselves might be really the way to go. And as we speak, there is a clinical trial with nicotine patch in mild cognitive impairment. There is preliminary results showing that it might be helpful, but I'll tell you why the patch might not be so helpful, and we need another way of administering nicotine in a few minutes. Before we talk about the other neurodegenerative, the second most common Parkinson's disease that you might all be familiar with, it affects the movement and then later on the cognition. It has definite, you get the tremor, the postural stooped posture, then you have the hypotension and many other prodromal conditions that precede the motor functions. And as you probably know, the deficiency there is in dopaminergic system. We have three main dopaminergic pathways in the brain. One is the mesolimbic that starts in the VTA and goes to the accumbens. That is dealing with the reward pathway. That's why nicotine affects that, and that's why the rewarding or the addictive components of nicotine. But in Parkinson, you have the destruction of neurons in substantia nigra. We really don't know why, but some genetic component, yes, maybe 10%, but most of it is idiopathic. We don't know the reason. Some environmental factors, yes, like paraquat or insecticides that the farmers use have higher incidence or exposure to a high level of iron or manganese. But by and large, it's the etiology is not known. And this pathway, the nigrostriatal pathway, gets destroyed. And knowing that dopamine is the transmitter that is reduced, the remedy was to increase the level of dopamine. And to increase the level of dopamine, you can have few ways. As you know, dopamine gets synthesized in the neuron, released in the synapse, affects postsynaptic receptors. One of the main mechanisms is to have it reuptaken back to the presynaptic terminal. So blocking this reuptake is one very important way, and there was actually Nobel Prize awarded for discovery of this mechanism and blocking this, which is also something that is used in depression that I'll talk about later. But anyways, you can increase the level of dopamine by blocking this or increasing the synthetic pathway. And in Parkinson, L-DOPA is the gold standard for this treatment. You can also inhibit the enzymes that break down dopamine in the synapse, like the cholinesterase with acetylcholine. Here, you would block the catechol-methyltransferase or monoamine oxidase inhibitor that are helpful, or you can even have dopamine agonists that act on dopamine receptors, paramipixole, etc. However, there are some limitations with these dopaminergic medications. Although their discovery in the beginning, L-DOPA, was a miraculous drug and could really relieve all the symptoms practically for at least few years, then it was found that in few years, it loses the efficacy. And not only it loses efficacy, but in few years, you have L-DOPA-induced dyskinesia, LID, that sometimes is worse than the tremor itself. And none of these drugs address the non-motor symptoms that precede the movement disorder. For example, loss of smell is one of the very first things that might be going, constipation, GI tract, depression, that is a very common comorbid with Parkinson, and sleep disturbances. None of these prodromal symptoms are affected by common medications. And the same with the cognitive impairments, so we need novel therapeutics. And that's where nicotine comes into picture. Of all the ill effects of nicotine, smoking, not nicotine, smoking that I mentioned, there is one epidemiological study or many epidemiological studies that consistently show an inverse relationship between smoking and Parkinson's disease. I want to pause here and emphasize, please, please, please don't go pick up smoking thinking that you're going to delay Parkinson, because you might not have the opportunity of this pleasure, because it can kill before you get to that age. So this gave us the reason to try nicotine in Parkinson's disease. And many clinical trials use nicotine patch to intervene. And I could have told them, don't use nicotine patch, because what's happening with the patch, you are giving a continuous stimulation of these receptors that you're causing desensitization. So you have to give nicotine the same way a smoker takes it, pulsatile. A smoker takes a puff, puts it down, in a few seconds or a little later, another, and then they have time between cigarettes, etc., etc. So what we say is you have to give nicotine by pulsatile, the same as in smoking. And we actually got a patent for just that idea, and we are hoping to try this procedure in some pilot studies. And I talked to Marta about this with some colleagues, perhaps in Argentina, that we might have a collaboration on this procedure. So I just want to emphasize that smoking kills, so this should not be the way, but pure nicotine as a therapeutic potential is something that we can work on. There is also age and sex dependency of addiction and use of nicotine. And basically, I just want to emphasize a couple of things. There is twofold higher levels of nicotine intake and faster acquisition of nicotine self-administration in adolescent versus adult. That's where the age difference comes in play. And also, in terms of the human studies, general, just a summary, we think that men practically smoke for the enforcing effects of nicotine, whereas women might smoke to regulate mood, that self-medication of depression that I was talking about earlier. So in addition to the nicotinic receptors, we have now the involvement of gut microbiota, and for all of you getting into the field, this is a really fertile area, and it's like a second brain that is controlling the homeostasis in the body. And we know now there is the gut-brain axis that practically all the functions of the brain might be mediated or affected by what's going on in the gut and vice versa. And you have even alpha-synuclein, that is a culprit in Parkinson, can get transported from the gut to the brain. And this axis is really a great thing to follow, and it's becoming very prominent in the field now. Gonna switch gears and go to alcohol again. 4 concepts: why addiction, the comorbidity, not only with psychiatric disorder, but also with nicotine addiction, the same neurochemical underpinning, and age and gender differences. Alcohol also has a very long history. So the evidence of alcoholic beverages were found 5,400 to 5,000 BC in Iran, my native country, then in Egypt, Babylon, and pre-Hispanic Mexico. However, the earliest evidence of wine production dates back to 6,000 BC in Georgia. But a couple of years ago, it was found that perhaps the same was in China about 7,000 BC. So it is as old as the human history, basically. And there is some reason for its use in many occasions. It is a very simple molecule, ethanol, that is derived from fermentation of many different grains. However, this has to be very distinct because grain fermentation gives you ethanol, whereas if you get the fermentation from wood, what we call wood alcohol, you get methanol that can actually be very toxic and poisonous. And this is what many people that synthesize, they think ethanol, but it's really methanol, and they end in blindness and so on. So what is the problem with the use of alcohol? It's not really the use, I should really say the abuse of alcohol, which leads to alcoholism or alcohol use disorder, a more common term to be used, and you get less than smoking afflicted deaths, but nonetheless over 88,000 in US alone. So the problem with this alcohol versus nicotine, smoking is basically affecting the person who smokes. Whereas with alcohol, not only it affects the person that is taking alcohol, but many other people, because getting under the wheel, behind the wheel, drunk driving, family practice abuse, and all kinds of issues. And I was surprised to see that this is not a one country, even in Scandinavian countries. I was surprised to see that Denmark had one of the highest incidents of the alcohol use. So why so popular? When I heard Dr. George Koop, director of NIAAA, giving a talk on the alcohol condition, he calls it coping mechanism. I call it escape mechanism, which is really probably the same thing. So we think, or I'm thinking, that people are taking these, maybe some like other drugs, to alleviate their stress. And this in 1920s, where there was the prohibition of alcohol in US, we know that it didn't work. There was many what you call bootlegging that were producing alcohol, and it was not just men demanding alcohol, the same with women as well. And the emphasis that it is to escape is highlighted in this passage from a story where this nurse, she said that if not for a little bit of spirit of liquor, it would have been difficult to carry out all the tasks assigned to her. So she was basically, this nurse, taking alcohol to escape this stress and be able to manage her job. And this is practically the same thing that is happening today We know, of course, pharmacologically, alcohol is a drug that has dose dependency. In United States now, 0.8% or 80 milligram percent is considered the limit. Some countries have zero tolerance. And because with this range, you have some high increased reaction time. But of course, as you increase the dose, you can get to coma, respiratory depression, and death also. Unfortunately, sometimes in United States colleges for admission to specific sororities or fraternities, they have alcohol intake as a measure of your tolerance. And some of these young kids are forced to drink to the point of death. And this unfortunately happens every now and then. So we, going back, can say that little bit of alcohol might have some of these increased appetite, etc. But so NIAAA would not want to say any of that because people, they say, oh, of course, if a little wine is good, so see what a bottle can do for me. And the same, this is an anecdotal thing I have found. So a little bit of it laughing out loud. I love everyone, carrying out loud, then starting to speak other languages, starting to dance. I'm fine, and then boom, to the hospital. So basically, alcohol is not the answer. It just makes you forget the question. Again, that escape from the stress of the question. So same thing with the nicotine, sacred alcohol. This was, I found this in my very old dorm. So it says, give beer to those who are perishing, wine to those who are in anguish or stress. Let them drink and forget their poverty and remember their misery no more. Basically, a great escape route, which unfortunately has the addictive component later and tremendous consequences with mortality, etc. There is also gender differences. Women may initially use alcohol as self-medication, again, for mood regulation, including depression, whereas men might use it as euphoria and especially in the adolescence. But nonetheless, however you started, eventually you develop dependence and tolerance, which means you have to take more and more to have the same effect, which can cause liver damage, cirrhosis, etc., etc. Now, one common comorbidity with alcohol is the fact that it's comorbid with depression. And depression, as you know, it's a very global condition. Basically, we define clinical depression. See, we all can be depressed at some time by loss of some dear ones, but those are temporary. When the symptoms last and are affecting the day-to-day productivity and function, then it becomes a debilitating condition, and we have clinical depression, which can ultimately lead to suicide, which is a very big problem. And there is also an interesting dichotomy between men and women. Suicide rate is higher for men than women. It's like almost over 3 times for men, although women are roughly 3 times more likely to attempt suicide. So men finish the job, whereas women start more, but overall morbidity is a lot more And this is, again, a big problem in military, especially with veterans, that at least one veteran a day is committing suicide. This is, of course, due to the stress and all that. What I want to get to now is the drinking and smoking, how they go together. This is a common scene. Now, of course, they prohibit smoking in bars, and you see that they have to go outside to smoke, but nonetheless, it's still a common condition. And there is a strong positive, like alcohol-dependent individuals are 3 times more likely than general population to smoke, and smokers are 4 times more likely to drink than general population. So they go hand in hand, but this combination actually increases in a synergistic fashion. Synergism in pharmacology means 2 plus 2 is not 4. 2 plus 2 may be 6 or 8. It's a multiplication or even worse. So both smoking and drinking, each one can increase the incidence of cancer of head, neck, esophagus, or duodenal ulcers by 5-6 times. When you put the two together, it's more like 30 times increase the risk. So why, despite all these risks, people combine the two together? So the contributory factors, and we have data to show all these, that there is, of course, a genetic component in both. There is pharmacokinetic interactions. There is pharmacodynamic interaction. I'm going to show a little bit of this data, additive reinforcement. There is of the reward component, then there is the analgesic component, and the counteracting mechanism. I mentioned that nicotine is stimulatory, alcohol is kind of inhibitory, and they counteract each one's effect. I'll show some data, at least stimulation versus sedation, and you have high level of alcohol that might cause neurodegeneration, and nicotine, as I mentioned, might have neuroprotective effect. So, and then you have also the epigenetic mechanisms that I would not go into. As far as the addiction is concerned, we know that there is the mesolimbic dopaminergic pathway that I mentioned, starts in the ventral tegmental area, goes to nucleus accumbens, and the release of dopamine in this area is what is giving the reward and pleasure. And practically any pleasurable activity, including all drugs of abuse, stimulate this pathway, albeit in different mechanisms. For example, one might increase the release, might block the uptake like cocaine, etc. But nonetheless, all have this stimulatory effect on nucleus accumbens. So we were thinking of how do nicotine and alcohol combine in this pathway. And interestingly, you have nicotinic receptors in both these mesolimbic and as well as the nigrostriatal pathway. So we said, would the combination of the two increase the level of dopamine in the nucleus accumbens? And we did the microdialysis that you might be familiar with, and we basically find that when we get the alcohol and nicotine together, that nicotine by itself has a ethanol by itself has a dose response effect. Then we see that nicotine also by itself has a dose response effect. And when we combine the low dose of alcohol with low dose of nicotine, we get much more increase of dopamine in mesolimbic system. This paper was published a long time ago and has been cited over 200 times, basically. And the same thing, if you give them in a higher dose, you still get the more dopamine release, and we can block this effect by nicotinic antagonist, mecamylamine, which is a non-selective nicotine antagonist, and basically you block this dopamine release by the combination of the two. So it means that they are both acting through the nicotinic receptors. Alcohol practically affects all the receptors, but also the nicotinic. So that's why the nicotinic system, and this is same paradigm in a different time course, and same thing that we can block the effect with mecamylamine with various doses. So you can summarize that alcohol and nicotine have additive reinforcing effect that might contribute to the reason why they would be taken together, and nicotinic antagonists may be of therapeutic potential in this suppression. This is still something that is under consideration for real practical purposes, actually. Nicotinic antagonists for alcohol and smoking. We have now varenicline, which is a partial nicotine alpha-4 beta-2 agonist that has been used for smoking cessation and is found to also affect alcohol intake. So in terms of the analgesic or pain reduction of the two, we also had some studies. Of course, pain has a different pathway. You have the central gray that is the center of the opiate receptors. And again, you have the various opiate receptors. You have the mu, delta, and kappa, various, and our hypothesis was that if you combine alcohol and nicotine, you get more stimulation of these receptors and you have the more analgesic. And if you give an antagonist of these receptors, you should block this intake. And indeed, or the pain associated with the lack of these two drugs. So basically what we did, we had two measures of pain. We have a tail flick and hot plate. Hot plate pain is associated with the central pathways, whereas the hot plate is associated with spinal pathways. So either one, when you give the so with the hot plate, which is the central, and the tail flick, we can see that both alcohol and nicotine have dose-dependent analgesic effects. And so the question was whether when you use the non-effective dose of each and you combine them together, would you get synergistic? And indeed, yes, when we combine the two together, we get the synergistic. And moreover, we can block the effects with opiate antagonists, and we tried all three different receptors. The one that is most effective is the mu receptor antagonist. All of them are effective, but the mu receptor antagonist is the most effective in reducing the analgesic effect of the combination. So again, if you combine submaximal doses of alcohol nicotine, you get analgesic effect in both pain measures, spinal, supraspinal, and if you give opiate receptor antagonist, you can block this analgesic effect. And in fact, for alcohol, naltrexone is what is being used for dealing with the alcohol use and, of course, the opiate overdose. So in terms of the counteracting mechanism where alcohol might cause toxicity and nicotine might be blocking that. We had we showed in cell culture that high dose of alcohol can cause cell death. And when you give nicotine, ethanol is causing death, and nicotine dose dependently blocks this toxic effect of alcohol in this. Actually, both primary cells as well as some dopaminergic cells. And again, we can block the effect of nicotine by mecamylamine, which is an antagonist. So alcohol, nicotine brings it down. Mecamylamine blocks the effects of nicotine. Not only mecamylamine, but also dihydrobeta erythroidine, which is a selective alpha-4 beta-2 antagonist, one of the more prominent receptor subtypes in the brain, can block this effect. And the other prominent receptor subtype in the brain is alpha-7, which can be blocked by methylylcacotinine or MLA, and that also blocks the effect of nicotine on protection of alcohol. So basically, we are saying that both, and the effect is mediated through apoptosis. We looked at the caspase-3 level in both cortex and in cerebellum, and in both cases, the combination increases apoptosis, rather alcohol increases apoptosis, and with the nicotine, we can bring it down, and mecamylamine can block that effect, basically. So to summarize this, in primary cell cultures, alcohol induces dose-dependent toxicity. Some of the alcohol toxicity is at least mediated via apoptotic, and the alcohol's toxic effect can be blocked by nicotine. So basically, in all three categories that I was talking about, we can counteract, or we have additive effects of alcohol and nicotine on reward pathway, analgesic pathway, and the counteracting mechanism adds to this co-abuse. What is the mechanism of alcohol action? In addition to nicotinic receptors, we have various pathways. So alcohol in ubiquitous acts on lipid membrane, heat shock proteins, many receptors, including nicotinic, and immune system. Actually, this was an interesting observation that during COVID, people with alcohol use disorder had worse outcome because of their suppression of the immune system with the high alcohol intake. High alcohol causes neuroinflammation, cytokine release, microglial activation, all of which can cause neurodegenerative and or neuropsychiatric condition, including depression. So this is why alcohol in high dose can cause all these problems. In contrast, and this I should be also careful in mentioning, low alcohol might have potential beneficial effects in that it might reduce the inflammation by decreasing edema or heat shock protein, decreasing microglial activity by decreasing cytokine and nitric oxide level. The reason that this low alcohol concentration with potential benefit came from these epidemiological studies where it was observed that, maybe anecdotal, but epidemiological in general, that French people, despite their use of high-fat diets, etc., that would affect their cardiovascular system, the incidence of cardiovascular disease is less. And this was attributed to the wine that they drink, because the wine, they said, has resveratrol that has antioxidant neuroprotective. Yes, wine does have resveratrol, but the resveratrol derived from wine is so little that you would need tons and tons to get to the therapeutic level. Then it was found that really the low alcohol itself is causing this protective effect, and basically it has protection against beta amyloid, etc., etc., without going into too much detail as the time is running out. So again, the same with nicotine. In addition to having the effect on all these receptors, cell membrane, heat shock proteins, etc., gut microbiota is, again, a very fertile area with alcohol research, as alcohol interacts with the gut microbiota and the gut-brain axis that can, as we know, affect the liver, kidneys, and so on. So this is also a very interesting area to concentrate on. One last thing I want to discuss, and this has been a puzzle to me, and maybe some of you can shed some light. So we know both alcohol and nicotine in low concentration have protective effects. So when we expose our SHSY cells to succinylol, which is selective dopaminergic agonist and toxic agent, we can block this toxicity by giving low dose of alcohol or low dose of nicotine. And this is not only in SHSY cells, but also primary cells. So you would think that if you put this low concentration of nicotine and low concentration of alcohol and low concentration of nicotine together, you would have additive or synergistic protection. But when we put the two together, not only we don't get additive, we get worse conditions just by themselves. If you just put the alcohol and nicotine together, you get worse. And of course, if there is succinylol, it's even worse. So this is a real puzzle as why this single use of low dose of alcohol has protection, single use of nicotine has protective effect, but when you put them together, you get toxicity. So this is something to be worked on, and we know that this has to do something with the caspase-3, as the combination low doses increases the caspase-3. This paper was published a while back, and this is just a reiteration of that study. So perhaps some of you can provide some answer to this puzzle. Take-home message overall, addiction is not an easy problem. Of course, if it was, we would have solved it already, and that men and women respond differently to different addictive substances, and there is usually comorbid conditions with substance abuse, as well as psychiatric and perhaps neurodegenerative disorders. And understanding the biological basis, what we are trying to do, can give us a hint in better prevention or treatment. And one fertile area is the gut-brain axis. And finally, my collaborators, and I hope to add some future people from Argentina. And with that, I thank you very much, and I'm open to questions.
Okay, so I don't know if you're gonna, Diego, are you gonna conduct the questions section?
Yeah.
Thank you very much, Yousef. That was very interesting.
Wonderful. Yeah, wonderful talk. Thank you so much. So yeah, so we are open for questions now. You can just raise your hand. So yeah, maybe I can start. So Yousef, this kind of relationship between nicotine and alcohol that sometimes enhance the abuse is also seen with, let's say, alcohol and other type of drugs, or even other kind of addictive behaviors like gambling or something like that. Do you think that I mean, obviously probably the molecular mechanisms are different, but this type of association also occurs, let's say, with marijuana or something
Yes,
like that?
absolutely. You're totally right. The co-abuse of substances of abuse, I don't know how to get rid of this
You have to
page.
stop sharing. I think you have to stop
Stop
sharing.
yeah.
Okay. How do I do that? Zoom.
Is it at the bottom or?
At the bottom, yeah.
Let's see. I can share. I see. Cancel. Share.
No, I think it has to be on the
You have
Zoom.
to, on the Zoom, yeah, maybe
And
at the bottom.
Maybe at the bottom there should be like.
Or maybe what I could do,
yeah, if you could please, because my
maybe let me see. No, I
seems
cannot.
like it's frozen.
There's a green button underneath that says share screen at the bottom of your.
Yeah, unfortunately, let me see if I can approach it. It's frozen. I'm sorry. And I cannot. Oh, okay.
There you go.
Yeah.
Yeah, perfect.
Perfect, perfect. Great. So, yes, absolutely. You have not only comorbidity with alcohol, opiates, cannabinoids, cocaine, everything. And it was thought, like usually the drug abuse starts with adolescence. That's where they start experiencing. And it is thought that alcohol and nicotine are one of the earliest ones. And it was proposed that these are gateways to other more potent substances that eventually lead to more stimulating drugs, more potent, etc. And yes, you are right. So there is the comorbidity with all other substances practically. See, the thing is, this is a very interesting issue, why the addiction and the reason for drug, like we said, it short circuits basically a natural reward pathway, right? And you would think that people that have accomplished all that they need, why would they revert to such substances that we see some very high addiction and eventually maybe even causing their demise and death, right? So we think that it's like you have saturated your reward system, and these drugs are giving you a boost on top of that. It's like a new era, which is really something that has to be thought about and see how you can address that, because it becomes not only a medical but also a social issue.
Thank you.
Yousef, I was thinking you mentioned this microbiome effect, which is so interesting. I don't know if you can extend a little bit more about that. I mean, how does it really affects the gut and the microbiome? Is it, I mean, or is there no real good studies on this?
So there are a lot of studies coming up on practically everything, not only drugs, but also the conditions, because what's happening with the gut, you can not only synthesize neurotransmitters specifically,
Yeah,
but
like
you can
serotonin.
you can synthesize or produce substances that affect those transmitters or get to the brain themselves and affect the brain there. So like right now, you have a lot of bacterial metabolites, specifically short-chain fatty acids. Some of them are detrimental, some are good. So this is where the condition of pre or probiotics come into play, where you want to increase the level of the good bacteria and suppress the level of the pathogenic bacteria. So this balance you can really affect by, for example, we know butyrate is a really good short-chain fatty acid, has neuroprotective, etc. And this might actually find a way into the practice as well, clinical eventually. So finding which pre-probiotics affect the different kinds of the bacteria is really something that, and there's quite a bit of literature on that as we speak.
Good. Yeah, it's so interesting. You know, the microbiome, I think, is so interested.
It's a
the
different
relationship with
brain almost.
Yeah,
really.
it's a second brain. It's a second brain,
it is.
absolutely.
It is.
It's a second brain.
And you know, this leads to that old adage. It's like they say, you are what you eat.
Exactly,
Really, it really falls into that. I believe. So.
Yeah, exactly. And what you drink as well.
Yeah. So, you know, eat, drink, moderate, you know, anything in moderation, honestly.
Yeah, exactly.
If you take anything to extreme, smoking, none, but maybe nicotine, a little, so.
Yeah, and a little bit of wine is not bad.
Yeah, that.
Yeah.
So I was giving this talk at NIAAA. So they say, okay, you can't say it's protective or it's good, but you can say that maybe a little bit of wine might not be harmful, like you said.
Exactly.
That's a good way of putting it. Yeah.
So the French paradox changed from resveratrol to think that it's really the alcohol that it's protecting.
I think so. Because the amount of resveratrol, and you know, for that reason, you have now compounds like this plant derivatives, resveratrol, curcumine, and so on, that really are neuroprotective, antidepressants, and antioxidant, and all that. But the bioavailability of this is so low that you would need tons of them. So marketing them on the, you know, they are not adequate to get to the brain. So you might get a little bit if you get a high dose, but really the bioavailability is a very big concern at the moment.
Yeah, it's true. It's true.
So maybe I missed it, but when you were explaining that the beneficial effects of nicotine can be achieved when there are pulsatile administration of nicotine, not just a constant administration. This is because of you think it's the sensitization of receptors, or why that could happen?
So, nicotine patch was developed to stop smoking, basically.
Yeah.
The idea is that when you put the patch, you are getting a continuous release of nicotine, and this nicotine gets to the brain and would reduce your craving because you have nicotine in your system already, right? And this is true. You start with the high dose of patch, and gradually you reduce it till you win it completely. When you are giving this patch, it's a continuous release. And this actually, we know in vitro and all that when you put continuous exposure to nicotine, you are desensitizing the receptors and keeping it desensitized. Whereas when you give it pulsatile, you're hitting the receptor, you're getting back, the receptor might be desensitized when you give it nicotine, but then it recovers quickly. That's why the next puff gives you a little pleasure. And when you stop the cigarette totally and go 5-10 minutes later, the receptors are back there. And the smoker says the first cigarette in the morning is the most pleasant. And the reason is because you have been deprived and the receptors are all back and sensitized to that, and you can get it going. So with that in mind, the receptor desensitization with the patch would not give you the stimulation that you need through pulsatile. And that's why I'm hoping to get with Marta and the neurologist to try this nicotine inhaler that is available in Argentina to try in Parkinson patients. We shall talk about that, Marta.
Yeah, okay. Okay, yeah.
And do you think that it's feasible? I don't know if they already exist, but if they are some kind of allosteric positive modulators of a nicotine receptor that can be a helper to nicotine action, maybe?
Absolutely, yes. I didn't mention, but that's a very good point. Now we know you can modulate nicotinic receptors by modulators that really by themselves might have all the benefits of nicotine, but maybe without the addictive component. Yes, this is actually what we are working on. And I forgot to mention, it's a really good point. Yes, there are some good possibilities of using the modulators rather than nicotine itself. Because when you say nicotine, there is always a hesitation. Oh, it's smoking, it's killing. But it's not nicotine that kills, it's all the other elements in cigarette, in the tobacco, whereas nicotine is possibly the therapeutic product, basically.
But alone, not together with the other things.
Yeah. Just which you can get by, nicotine patch, but also now we have nicotine inhaler or nicotine nasal spray that is pure nicotine. And actually those work better for smoking cessation because they mimic the pulsatile taking of cigarette by the patient.
Exactly. Good.
So, and this is more kind of more law related question is, and you can get nicotine just there in the state freely. I mean, for this to inhalate or something, you can buy it.
Nicotine inhaler.
Yeah.
Yes, they are available on Amazon, and there are actually very interesting anecdotal videos, people saying that they have this, like I mentioned, the LID, L-dopa-induced dyskinesia, that there's like a video saying that when the patient thinks that might be coming on, they reach for this inhaler and it affects them. So there are few videos actually on YouTube. Maybe mine would help with that. I don't know.
But these nicotine inhalers are not the same as the electronic cigarettes, no? It's not the same.
Absolutely not.
No.
Electronic cigarettes are not tobacco. They are giving you nicotine, but there are also many other elements, and there are many publications about the hazard of
exactly
cigarette, which they don't tell you what is in it because it's a proprietary patent or whatever, but they are in general probably less harmful than tobacco because they might have less number of harmful elements, but nonetheless they are harmful, and it is very different from pure nicotine.
Yeah.
Yeah.
And I heard that it's the hazard might also be because it forms like little bubbles in the lungs, I heard, and that's really not really very good for these kind of electronic smokers.
Yeah, it's really substituting cigarettes with another device, which is Not as harmful, but still pretty harmful.
Still, yeah, exactly. So good. So it seems people are not asking anything.
Yeah, I see Miriam on there. She
Miriam, yeah, she usually goes to yeah.
to NTS meeting, right?
Mm-hmm.
Okay.
Okay.
Yousef, nice to see you.
Hi.
Hi, Miriam.
Miriam.
Excellent conference. Thank you very much. Hi, Marta. Hi, Eva.
Hi, hi.
Pleasure to see you. It's been a while.
Yeah, hope to see you next NTS meeting, hopefully.
I hope so.
Yeah, you know, we have this neurotoxicity society where Miriam usually goes, and of course, Yousef and myself, we always go. It's a small society, but it's a nice society related to neurotoxicity and everything related to neuroscience in a way.
Nice.
Yes.
Martha
Okay.
is going to be the next president of that society.
Yeah.
Cute. Mickey Ashner is there as well.
Yes.
Yes.
Yes, exactly.
I don't know if he went to this one. I guess no, right? The last one.
To the last one, no, as far as I know.
Yeah.
Yeah, the one in Bahia, no, he was not there. Okay, so
Okay. So, well, Yousef, thank you so much for your talk, for accepting the invitation. It's very important for us, for the society, for everyone here. So, and hopefully, yeah, it would be great to have you in person, probably in the following meetings. That
Maybe
would be
next
awesome.
time I visit Argentina.
Sure.
yes, to see your grandson, you can also see us. Hello, Diana.
Okay. Diana.
Córdoba as well, Yousef. You are invited to Córdoba as well.
To Córdoba, yes, and to Bahía Blanca, everywhere.
Yeah.
Right. I'll arrange a tour of Argentina.
Yeah.
Argentina,
Very
yes.
good.
You
Very
need
good.
to stay,
All right, we'll keep
quite
it.
the way here.
Very good. We'll do. Yeah.
Okay.
I don't know if I would have much new info, but we are working on actually a paper with Marta on schizophrenia. So there are a lot of other things I might be able to talk about.
Great.
Nice.
That would be
Yeah,
great.
perfect. Yeah.
Looking forward.
Same here. Thanks very much again. It was a pleasure.
No,
Okay.
thank you for accepting to give this seminar. And well, next time we could be in person then.
Hopefully.
Okay.
Okay.
So
Okay. Thank you, everyone.
bye-bye.
Thank you,
Thank
Yousef.
you very much.
Bye-bye.
Say goodbye to Vera.
Thank you.
Bye-bye.